for the next two cases of pancreas and its complications and malignancy of the pancreas. I welcome all of you on behalf of Gastroenterology, Jinnah Hospital, Lahore. We will move to our case number 3. I will request our worthy Professor Farooq Afzal Saab to please come on the stage and have a seat, sir. Professor Farooq Afzal is the Professor of Surgery and Dean of Surgery Division, Lahore General Hospital, Lahore. And now I request Professor Khalid Mahmood Khan. He's a Professor of Medicine in Jinnah Hospital, Lahore. Thank you, Dr. Farooq Afzal, please. Now I request Dr. Adnan Salim to please come on the stage and have a seat, please. He is the Associate Professor of Gastroenterology and Hepatology in Sheikh Zayed Hospital. He has got many papers on the portal hypertension under his name. Now I request Professor Akif Dilshad to please come on the stage and have a seat. He is the Professor of Gastroenterology and Hepatology in Lahore General Hospital. I will request Dr. Fariha Shams to come on the stage. Dr. Fariha is the Associate Professor of Radiology in Lahore General Hospital. She is certified endosonoradiologist from International School of EUS. Dr. Fariha, thanks for your presence. Now I request Dr. Bilal Nasir to please come on the stage and have a seat, sir. Dr. Bilal Nasir is the Assistant Professor of Gastroenterology and Head of Department in Gastroenterology Department of Gulab Devi Hospital, Lahore. For the moderator of this session, I will request Dr. Moeed to please come on the stage, and I will request Dr. Mohibullah. He is the Fellow of Gastroenterology in Services Institute of Medical Sciences. Dr. Moeed, please come.
Assalamu alaikum, everyone. Case 3 is a very interesting one based on cystic lesion in the pancreas. Dr. Mohib will present the case.
Thank you, Dr. Moeed and respected panel, for giving me this opportunity to present this interesting case. Cystic lesion of pancreas. History: a 26-year-old male, married, farmer from no previous history, farmer by occupation, and resident of the Jati Umrah, presented with history of fever for the last 2 months. That's low grade with evening rise, released with paracetamol, and associated with significant weight loss of 7 kg. There is no other remarkable history like cough, diarrhea, abdominal pain, rashes, joint pain, petechiae, heat intolerance, and there is no any remarkable history of personal and family. Patient was vitally stable and abdomen was soft, non-tender with no visceromegaly. Rest of examination were unremarkable, no lymphadenopathy and no rashes. This is the investigations that was normal except low normal HB, 11 gram per deciliter. Ampicillars tests were advised that turned out to be negative. HIV serology was also negative, and thyroid function tests were also normal. This is the chest X-ray of the patient. Blood culture show no growth. On ultrasound imaging, there was a solid looking well-defined mass of 3.5 into 2.3 into 1.7 centimeter noted in the head and neck of pancreas.
I'd like to involve a worthy panelist here. Professor Khalid, seeing this patient, this young patient, he had this ultrasound done showing a solid mass of 2 to 3 centimeter. So what is your approach in terms of moving forward further investigations?
Thank you very much. First of all, I must congratulate Professor Shaisarwar and his team. As you know, this case having a solid mass in pancreatic head, I will go for CT abdomen with oral and IV contrast. The best way is triphasic CT and along with CA 19.9. However, as this patient who is young, only 26 years of age, and there is no family history of tumor, if we see pancreatic tumor, the age is usually, peak age is among male between 65 to 70 years of age, and for female it's usually more than 70 years of age. But in this case, age is only 26. So I must rule out other causes as well, because patient gave history of fever for last 2 months, and I would like to go for blood culture, and for especially those conditions like I will go for long-term history of fever. I will go for I mean to say to work up for tuberculosis as well.
Dr. Bilal, what are your thoughts regarding what is your preference in terms of choice of modality in this case, CT versus MRI, and what are the pros and cons of both?
Thank you very much. Actually, when we are dealing with any lesion which is in the pancreas, whether this is cystic or solid, we have to investigate it with CT. CT has its own significance with pancreatic protocol because we can have a better assessment. But if we are dealing with the pancreatic lesion, the MRI always have a superiority, MRI with contrast or dynamic MRI with MRCP, because that would tell us about the relations, enhancements, T2 intensity, as well as the association with the pancreatic duct as well.
Can I make a comment here?
Yes, ma'am, please.
Basically, I think radiologist's role is very important here, and I must say the physician should let the radiologist decide what investigation should be performed next, whether it should be CT or MRI. So we have different options for both of them. As far as CT is concerned, it's basically can be monophasic, which usually is which we are usually doing in most of the patients unless there is a specific indication for going to another phase. Preferably it is performed biphasic, not triphasic, and by biphasic I mean a plain CT and then a portovenous phase, because that shows the parenchymal enhancement pattern. There is no role of delayed imaging as far as pancreatic masses are concerned until we are interested to see any fibrous tissue in there, which will show enhancement in the delayed phases, which is taken after 3 to 4 minutes of contrast. And MRI is definitely a modality of choice now, because you must be knowing that CT dose, when it is conducted monophasic, that is around 7 millisievert, and which is equal to 2.5 years of background exposure to radiation. And when you conduct a biphasic CT, that is 5.6 years. That means double the dose which we are conducting in monophasic. So this is very, very important to carefully calculate and evaluate which investigation you should be following, CT or MRI. And definitely MRI has superiority over CT in many aspects, especially in the cystic lesions, because it characterizes the lesion very well. And secondly, we have the option of multiplanar reconstruction in there, and we can have MRCP images with heavily T2 weighted images and haste sequences. So MRI is definitely superior for CT. And why not EUS? I think after transabdominal ultrasound, if we have found a solid lesion and the radiologist reports that it is a sinister looking lesion, at the end you have to go for biopsy, right? So why not EUS first? So it's just a question that I put in front of the panel. Thank you.
Something here.
Yes,
so I will basically play the roles of devil's advocate actually. What I've seen is the clinical reasoning is so important for us, and most of the time we doctors apply either a deductive reasoning or inductive reasoning. Now, in our setup, if somebody comes to you, I think you should be able to make a hypothesis about the possibility of the diagnosis based on history first, because investigations are later on. So if a person who has got no history of pain, has got fever for the last 2 months, my mind would be saying either this patient has infection or inflammation, right? So we need to teach our resident how to start with the process of hypothesis generation and then come up with the physical examination, and then we should ask for investigation. And the fundamental principle of investigation is you ask a clinical question which you need to answer, right? Well, suppose in this patient, my first diagnosis would be this is probably 2 months of fever. I'm probably thinking of liver abscess, tuberculosis, right? And if he's got some bowel symptoms, I probably would also think of some inflammatory bowel or other things. So in this situation, if I have to design my investigation, this should be based on number one, what is the clinical question I need to answer? And number two, if that investigation is positive or negative, what would be the consequence? Because doing an investigation without expecting is it going to change the management plan or not is totally wastage of resources as well. So I would say that we should focus on the basics of medicine, which is clinical reasoning.
Dr. Fariha,
have we done the inflammatory markers in the patient?
ESR was done, it was 55,
Okay.
slightly less. Ma'am, another question, we often hear the term pancreatic protocol. For our junior colleagues, what exactly is pancreatic protocol, how it's done, and what are the benefits?
So pancreatic protocol, we do follow in CT, CCT, and MRI as well, which the proper pancreatic protocol. We have different protocols for different lesions. If we are looking at a solid lesion, then we will go for the biphasic CT, which is plain CT, and then the pancreatic parenchymal phase, which is required after 40 seconds of the contrast injection. In why 40 seconds? The parenchyma actually enhances a little bit later than the other viscera, the pancreatic parenchyma. So in that time period, we catch the pancreatic parenchymal enhancement pattern. And if any lesion sitting there enhances less than the surrounding parenchyma, that becomes suspicious. So, and otherwise, normally we just conduct the pancreatic protocol in single phase, which is monophasic CT, and in that we just do the portovenous phase and no initial scout film. Then in the MRCP, if you are talking about the pancreatic MRI, we have multiple sequences, and it's I'm not sure if you can just get the MRI out of my discussion, but basically it's heavily T2 weighted images that we acquire, and then we post-processes into MPR, and then we build coronal MRCP images. By using oral contrast, it can be negative, it can be positive contrast. And for cystic lesions of pancreas, take my words, MRI with MRCP is a better modality of choice than going for CCT pancreatic protocol. Yeah.
We have the final word, MRI over CT from the radiologist. Can we move forward, Dr. Mohit?
Based on history, multiple differential were listed. And according to that, tumor marker CA99 was advised, which turned out to be normal, that is 3 units per ml.
Dr. Fariha, could you please elaborate on these CT images?
Yeah, so these are the CT exit slices of abdomen taken from the diaphragm level up to the probably iliac crest. That should be the pancreatic protocol. And since we can see the portal vein opacification, the aorta, and the IVC a little bit, this is the portovenous phase. So this is actually conducted in the pancreatic protocol, observing the pancreatic protocol. So here as I scroll down, this is actually a heterogeneously enhancing solid and cystic lesion, which is involving the head and neck of the pancreas. And as I scroll down, it's basically the, I'm sure you can appreciate the vessels here, which are being splayed by the mass, not encased by the mass. So as I scroll further down, yeah, so this is important. Here I can see something which is hypoattenuating, and this is rounded, well circumscribed lesion which is in the aortocaval window, most likely a necrotic lymph node, and this is a very, very big bullet point here. So as I scroll down, I can see multiple other lymph nodes as well, which shows central necrosis. And by central necrosis, I mean that on CT, they will be showing low attenuation centers. So pancreatic duct is not dilated, and the rest of the pancreatic parenchyma, including the distal body and the tail, which is you can see here at this hilum, they appear unremarkable. The intrahepatic and extrahepatic biliary channels are normal. They do not show any dilatation. And as far as the rest of the scan is concerned, let me quickly go through the axials. Yeah, so a little bit of pelvic ascites here, and that's it. Yeah, so in my routine practice, what I do is that I change the window as well, and I tend to look at the bone window as well by switching to the bone window from the default window. That will exclusively rule out any sinister looking osseous lesions. So in short, this is a solid cystic enhancing mass involving the head and neck region of the pancreas. Here I would request the presenter to kindly run my slides of cystic lesions.
So we had a cystic lesion. We had taken the opportunity to request Dr. Fariha to guide us regarding different pancreatic cystic lesion, how to differentiate between them radiologically.
So I'll just quickly go through the multiple cystic lesions that we can have in pancreas. They can be unilocular, multilocular, they can have solid components or mural nodules, and they have different locations in the pancreas involving the body, head, neck and tail of the pancreas. Although no lesion comes after reading book, but still there are some incidences, percentages by which we can evaluate that which lesion will most likely be occurring in the body, tail or head of the pancreas. These are some of the lesions that are shown here. We have serous cystadenomas, mucinous cystic neoplasms, then cystic neuroendocrine tumor, solid papillary tumor, and then main duct IPMN. So again, these are multiple cystic lesions, and grossly as a radiologist, what we are supposed to know in the cystic pancreatic lesions: number one, whether the lesion is benign or malignant, right? Number two, whether it is communicating with the duct or not. Number three, is there any solid component within the cyst? So these are the 3-4 basic points that the radiologist should be addressing in his report. So the lesion can be benign, malignant, and the benign lesions can be serous cystic neoplasm, mucinous, and then it can be IPMN and side branch and main duct IPN. I'm sure everybody knows the classification here. So I'll just be showing quickly the few images of the cystic lesion of pancreas. Here you can see there is a large, well-defined, well-circumscribed, low-attenuating cystic lesion involving the tail of the pancreas on the left of the screen, and a very thick, peripherally enhancing lesion with thin septations on the right of the screen. The left one is pseudocyst, and the right one is a neoplasm. And what kind of neoplasm? Mucinous cystic neoplasm, because serous, they will appear mostly solid on CT, and they will give a honeycomb appearance after contrast administration, and then EUS, they will be honeycomb appearance of the serous cystic neoplasm. Again, this is a EUS image showing you a pseudocyst here with no debris, and if you put the Doppler here, there will be no vascularity within the lesion or within the wall. Again, this is a corneal reformate showing you a simple pseudocyst, and for pseudocyst, there must be history of acute or chronic pancreatitis or trauma. So again, these are traumatic pseudocyst here, pseudocyst with debris, and for pseudocyst with debris, MRI with pancreatic protocol is a must. So you should go for MRI with pancreatic protocol to rule out any debrinous material here, because mucinous cystic neoplasms can mimic the pseudocyst with debris. Here, this is the serous cystadenomas with central scarring, which is a book picture of the serous cystic neoplasm. Not all the serous cystic neoplasm appear like that, but here for the central scar, which is fibrous tissue, that will be very visible on the MRI sequence T1, T2, both hypo intense. Again, this is serous cystic neoplasm with calcification. If they do calcify, then they calcify from the center. The fibrous scar actually calcifies. So again, this is a few pictures of the MRI and coronal MPRs showing central calcification, thin septations of the serous cystic neoplasm, and the central scar in the MRI sequence. Now this is again the same thing. Now mucinous cystadenomas, this is a tumor which is unilocular mostly, but it can be bilocular, multilocular, in which you will be seeing enhancing walls, irregular septi, and peripheral calcification, not the central calcification. And on the screen you can see cystic mass lesion on EUS as well. It becomes very clear on EUS, I must tell you, that EUS is a very good modality to aspirate the fluid and to look into the lesion and characterize it better than CT, obviously. Again, this is a multiloculated, multiseptated peripherally enhancing lesion which shows enhancement of the septi and peripheral calcifications, and you have the EUS image as well. This is how the mucinous cystic neoplasm looks like. Don't you think it looks like pseudocyst as well? So it mimics pseudocyst. But what gastroenterologists can do, if they do ERCP, they will be seeing bulging papilla in the mucin column test, whatever you do, that is your domain. But this is the mucinous cystic neoplasm with peripheral calcification and thick enhancing periphery. Again, this is a simple cystadenoma showing the same features. Now, this is the main and branch duct IPMN, which is another cystic lesion which we quite often see in our practice. If that causes the pancreatic ductal dilatation, that is a very good point to differentiate it from the other cystic neoplasms. It can be main duct, in which case the pancreatic duct will be hugely dilated. But as a radiologist, I must confess that sometimes it becomes very difficult for us to differentiate between the main duct IPMN and chronic pancreatitis. So that is actually question that arises in our minds while we are reporting. What is it? It's MCN or it is IPMN? So again, this is branch duct IPMN. When you have multifocality, multiple cystic lesions in the pancreas, that is basically branch duct IPMN until proven otherwise. So again, this is the young age tumors, SPEN, which is seen in young girls with solid cystic component, and this has low potential for malignancy, and it does not metastasize until late. So, and it is a very good prognosis. Sometimes we do see cystic degeneration of the neuroendocrine tumor, but this is a very easily differentiated tumor because if we get arterial phase, it will show rich enhancement post-contrast. So that is a very easy diagnosis to make. Again, this is the same thing, islet cell tumor with the mural nodule here, which shows enhancement on EUS image as well. Now, as Dr. Farooq Afzal was pointing out, that the patient is presenting with history of fever for 2 months with raised ESR. Why not infection or inflammatory process going on there? So sometimes, although it is a very rare case, but we do see pancreatic tuberculosis as well. And it becomes very, very difficult as a radiologist to differentiate pancreatic tuberculosis from the tumors. So in that case, we would ask the colleagues to go for the biopsy, for fluid aspirations, and for PCR testing for tuberculosis. So here you can see the right lung is completely involved with consolidations, pleural enhancements, and then you have pleural effusions as well. And on the axial images, you saw the pancreatic hypoattenuating mass of tuberculous granulomas. So, yeah, thank you.
So we have the CT images. We have a solid cystic lesion of 3.1 into 3.5 centimeter. Professor Farooq, I'd like to take your input here, sir. Sir, what would be your strategy in tackling such a case, or even a regular case where there is a solitary pancreatic lesion and probably there is no history of fever? how would you like to proceed? Would you like another modality for further investigations, or is this CT enough for you to
Yeah,
go
so
for
this
surgical
is
management?
something which was not, I was not expecting this one, right? Because the clinical history was totally not matching with this incidental finding. So it needs endoscopic ultrasound to basically, first of all, clarify it and maybe take a fine needle aspiration and cytology. I'll probably go for amylase levels and I think the cell cytology from the fluid, just to ascertain what sort of it. I mean, the CT picture is, we see mostly in young girls the pseudopapillary. They are much more common, or sometimes these mucinous ones. So I think I will take the help of my gastroenterology colleagues to do an endoscopic ultrasound and help us with the biopsy or a needle biopsy cytology of this, to take fluid as well as cytology. So I would refer them to.
Sir, is that your practice in all pancreatic lesions? What if
so we are very fortunate. We are very fortunate. We have a very established gastroenterology units here. So we have a good liaison with them. Every cystic lesion usually is referred to the gastroenterologist first of all.
Dr. Adnan, what are your thoughts regarding further plan of action, sir? We have the CT scan.
It's definitely sure that as per established studies, as per guidelines, especially the 2024 AGCC recommendations, an EUS guided approach is the way to go. And in that regard, if you're looking at other modalities as to how you can get a diagnosis, for example, if the GI team is involved, it has been established that an ERCP guided brushing isn't going to achieve much results. If you're going to go for an EUS, and since we know prospectively that we are possibly dealing with an infective etiology, but regardless of what it is, we already know through various studies and meta-analyses that we are going to be achieving a higher level of sensitivity and specificity by getting a specimen and subjecting it to AFP analysis, and progressively, if you go on for PCR and then again for culture, successively higher rates, even up to 80% of sensitivity. So EUS is definitely the way to go. And studies have also established that ultrasound, basic abdominal ultrasound, and CT-guided aspiration, FNAC, are not superior to EUS-guided, because it allows for more detailed local regional imaging and a better approach. So yes, in this case, you do an MDT, and then if the next step is a diagnostic sampling, EUS is the way to go.
So we had endoscopic ultrasound done for this patient. Dr. Mohib, could you please resume?
Endoscopic ultrasound was performed on this patient, and the findings were heterogeneous lesion adjacent to the pancreatic neck with no vascular involvement, and FNAC was obtained.
Professor Akif, as someone who is regularly doing EUS and advanced procedures, could you please describe this image and also guide us regarding how to differentiate between different pancreatic cystic lesion and endoscopic ultrasound?
Last image दिखाइए तो अगला आ गया आपका. हाँ, this is the image of the patient. It's a cystic lesion with some solid component, and as we take it with the history, that patient has got a long-standing history of fever and weight loss, and we are suspecting chronic infections as well. And it's not a typical cystic lesion, other than it's got a significant solid component. So differential could be, other than the tuberculosis, the differential could be a necrotic tumor with maybe a solid tumor and some necrosis with liquefaction. That could be is one possibility, and even the sometime NET may present with neuroendocrine tumor may present with necrosis, and cystic NET is also a possibility. So I think whenever you see such lesions, you need to take the fluid for analysis, and with the solid component available, you would also like to take the biopsy of that as well. So was the biopsy taken? So these are the lesions just to, it's already been discussed.
Can I interrupt you? I mean, you're taking the cyst cytology as well. What about the lymph nodes? Would you attack the lymph nodes same time?
It depends what is the size. If the short axis is more than 1 centimeter, yes. If they are rounded, yes. If they have lost the hilum, yes. but on CT it looks like smaller size. What was the size?
So about the lymph nodes, it was initially basically the proposal was to go for the size, but now since we have micrometastases as well, so the lymph node shape and internal attenuation, they are better predictors of involvement in the disease process than the size only. In this case, the utocable nodes that I showed you on the CT scan while I was reading that was rounded and that has low attenuation center, which means that it has gone necrotic change or cystic change. So we have just two differentials in our mind as a radiologist while reporting that case. If we see low attenuating lymph nodes retroperitoneally, number one is MCN metastases, number two is TB, until proven otherwise. There is no third differential here.
So
one more thing, sir.
Sure.
Just an anecdote. Studies have shown that, well, not always, but usually in cases of pancreatic tuberculosis, you tend to see less vascular involvement, and you tend to see, as opposed to other lesions that you see in the head of pancreas, you usually see pancreatic and common bile duct dilatation. These are less common in cases of tuberculosis. So usually you have a mass, but you would see normal ductal diameters and no jaundice, and very less occurrence of jaundice in such cases, sir.
So,
just a little point I want to make here, that vascular involvement is not rare in TB, it's not there in TB. So the vessels are splayed around the mass, which is seen in pancreatic TB. However, in case of malignancies, the vessels will be encased or will be thrombosed. So in case of pancreatic TB, the vessels will be splayed by the mass. They will not be involved.
So the message is, if you think that the lymph nodes are involved in terms of the shape, that it is rounded, if the size is significant, short axis more than 1 centimeter, and you've got the loss of hilum, then you would like to take the biopsies from the node as well. And if you want to do both in one sitting, it's better to go first for the lymph nodes and then to the main lesion, rather than main lesion and using or you use separate needles, so that if the lymph nodes are not involved by a malignant process, you may not treat them. So you do the biopsy from the nodes first if you want to do, and same needle can be used for the lesion or two separate lesions. Here are a few images of EU has already been discussed by Dr. Fariha, previous one. So cystic lesion of pancreas, if you've got peripancreatic fluid collections, generally thin walled. Next. So the original concept of cystic lesion is that you need to differentiate benign from the malignant lesions. So it is important that you know the characteristics of benign lesions and malignant lesions, malignant cystic lesions. So this is one of the lesions who got microcystic appearance, that is less than 2 centimeter multiple cysts, and part of it may be having sub-centimeter cysts in the center, may not be looking up very well here, but what we call as honeycombing. So 50% of the serous cystic neoplasm show these microcystic or smaller cysts that we have seen multiple, and they may present with macrocystic as well, or mixed picture as well. So here you can see, so these are the microcysts less than 2 centimeter, and here you can see this is very small sub-centimeter cysts that maybe if there is bunch of it, we call them honeycombing. So this is characteristic of serous cystic neoplasm, but serous can present with macrocyst as well. 50% of them are typically microcystic, and the rest maybe 20-30% may be mixed or macrocystic. Next. So this is typical macrocystic. If you see large cysts inside the cyst, so these are likely to be mucinous cystic neoplasm. Mucinous can also present with a single large cyst, and they mimic with the pseudocyst, a single cavity, but you can very well differentiate by aspirating it within the MCN. There will be clear mucinous thick fluid, and the glucose content will be very low. But in MCN, but in pseudocyst you will have debrinous fluid, brownish colored, and there will be a history of pancreatitis as well. Next slide. And पिछले वापस कीजिएगा. And here you can see there is a solid component mural nodule as well. So if you find this mural nodule, you need to target them to get the biopsy. There may be some sinister thing brewing up. Next slide. So here you can see again multiseptated cystic lesion, and whenever you see multiseptatic, you need to see whether it is communicating with the duct or not, because they look similar with MCN and with the IPMN side branch IPMN. There are multiple grape-likes, but here you can see in the next image that this is communicating with the side branch of pancreatic duct. So once a grape-like appearance communicating with the pancreatic duct, that tells you that this could be IPMN, side branch IPMN. IPMN could be side branch, could be main duct, or could be mixed variety. So there are high chances of malignancy, especially with the main duct or mixed variety IPMN, up to 40%. Next slide.
So the histopathology.
Histopathology of an SNE sample was obtained which show aggregate of the epithelioid histiocyte and few lymphocytes suggesting of caseating granuloma. Culture report received after 3 weeks and Mycobacterium tuberculosis was isolated.
Has he got a family history of tuberculosis? Did we investigate that?
So he didn't mention it.
He didn't mention it.
He didn't mention it. Now we had this surprising histopathological diagnosis, very rare presentation of very common disease. Professor Khalid, like your thoughts here, sir, as someone who's also internist and deals with this disease regularly, what would be your approach here? For how long would you like to treat?
Thank you. Case is quite typical now. I think so for my junior PGs, nowadays it's very difficult for us. It's very easy because we used to treat split regime, but nowadays it's myrin P4, first 2 months, followed by 6 to 9 month therapy of simple myrin. But for PGs, I must elaborate the regimen. For isoniazid, you need 5 milligram per kg body weight. For rifampicin, 10 milligram per kg body weight. And for ethambutol, you need 20 milligram per kg body weight. And pyrazinamide, 30 milligram per kg body weight. Remember, these 4 drugs needs to be given. So myrin P4 में ये चारों हैं. So that you have to give in the initial phase for first 2 months, followed by, depending upon the availability, like in the past, rifampicin, isoniazid was easily available. Isoniazid 100 milligram tablet was available. Another thing, whenever you are giving isoniazid, please take the history and follow the patient, whether patient gives you signs and symptoms of peripheral neuropathy. If that is the case, then you need to give pyridoxine 10 milligram for every 100 milligram of isoniazid. But we have tablet of pyridoxine beta 6 के नाम से, that is 50 milligram tablet. So that you need to give in case peripheral neuropathy. Similarly, for ethambutol, optic neuritis and color vision disturbance, these are quite common, and hepatotoxicity. Similarly, for pyrazinamide, hepatotoxicity and hyperuricemia, that you need to keep in mind. Thank you.
Dr. Bilal, sir.
That I want to highlight that these days the ATT drugs are difficult to find, especially if you have got hepatotoxicity and you need to adjust the dose. These are not available in the market, rifampicin, INH, and so this is a significant issue. Do you people face this difficulty? I at times tend to find, and it is not available in the market. And
that's why I said in the beginning that we used to have all these drugs like ethambutol was 400 milligram tablet thi, and you used to give 3 tablet in 70 kg person. Similarly, pyrazinamide 500 milligram ki ek tablet thi, and that you need to give. So more or less, you have to give 11 to 12 tablet for treating tuberculosis in the initial phase, and subsequently you need to give one capsule of rifampicin, 450 milligram or 600 milligram, depending on the weight of the patient, and isoniazid, 3 tablets usually you used to give. But nowadays you have all these in combination, and you are absolutely right. We face lot of problem whenever there is hepatotoxicity or other side effect of these drugs.
Dr. Bilal,
A quick question from Dr. Akif. Dr. Akif, if you see a multiseptated cystic lesion, pancreatic cystic lesion, while doing EUS, what's your approach? You'll go for aspiration and as well as mural nodule biopsy, or you just do the aspiration and leave the biopsy? And what actually is the cutoff point if you intend to do biopsy of the mural nodule?
If the mural nodule is there, it has to be targeted. So there are two approaches. Some people first target the mural nodule and then do the aspiration, or other aspirate it initially and then target the nodule. In our experience, we have seen that if you drain it completely and then target the solid nodule, you may not be able to find it, you may find it difficult to target. So you aspirate maybe a bit of it, and when there is some fluid left, you intend to target the mural nodule. And you need to distinguish it from the mucus plug as well. In cases of MC analysis, the mucus plug or a real solid component or a mural nodule.
So any size, any cutoff size which you
I think
have
more
in
than
your
5
mind?
millimeter has to be
More than
targeted.
5 has to be targeted. And if it is less than 5, you just leave that.
Even then, you attempt to target it, and you may not get much out of it.
So my question, Nasir, is just, we know that there is deficiency of these ATT medicines. So what would be the second line or third line so that people could get benefit?
Second line, third line.
Again, we have multiple drugs available, like even simple quinolones. You can, maximum trials are on ufloxacin, and then moxi, and then ciproxan. That can be used for second line drug as well. Similarly, there are other macrolide can be used as a second line drug.
So for how long? I mean, with the same duration or different duration?
It's very difficult to answer this question, but more or less you have to use these drugs for longer duration of time, and you need to keep side effect of these drugs as well.
So as surgeon, we use this
One
streptomycin.
point.
Yeah.
Just the aim is to tide over that time, and then you add one by one, if available, the first line drugs. You need to switch back to the first line if possible.
Yeah.
Another streptomycin, again, that is that 1 gram injection, and you have to give deep intramuscular injection. Nowadays you are not using commonly, but it was being used as a routine for first 3 months. So daily deep intramuscular injection for duration of first 3 months.
Actually,
Dr. Bilal, what's been your experience, sir? Have you dealt with such a case? How have they fared? How do you follow up such a case?
If we go with the guidelines, unfortunately, because this is something which is a rare case. So in treating a tuberculosis patient, the guideline shows that if we have either tuberculous meningitis or bone tuberculosis, we need to give the ATT for 12 months. Rest all, whether this is pulmonary or extrapulmonary tuberculosis, the treatment is 6 months. But for pancreatic tuberculosis, we don't have a data, so we cannot comment on particularly for this case for how long we need to continue with that. Secondly, the question which previously Dr. Farooq has said, that if we have a problem with this, there are different regimen for like if we develop ATT induced hepatotoxicity in patients with tuberculosis. So first thing is that we have to stop and assess the patient. It all depends on the clinical assessment, that in which condition our patient is. If we think that patient disease can worsen, so we can shift to the zero hepatotoxic regimen. But zero hepatotoxic regimen includes streptomycin, ethambutol, and the quinolones. But we need to give it for at least 24 months. So that would be the intensive phase of 6 months, and then after 18 months we need to continue with that. But we have to monitor it in between. If once the ATT LFTs get settled, so we reintroduce these ATT one by one. And the duration of treatment would be for 9 months in those cases. But rest, the WHO says that the pericardial effusion, the tuberculosis meningitis and the bone TB should be treated for longer period of time. Even with intestinal tuberculosis, we need to continue it for 6 months, not more than that. Thank you.
We have a question. From
Just to add about the duration, I do agree with Dr. Bilal that there isn't a specification of duration, but the small number of studies and case series that we have on patients on pancreatic tuberculosis, the duration has been, again, not specified, but it is between 9 and 12 months, so they're not sticking to 6.
Dr. Fariha, how would you...
Just a minute. We also see an epidemic of atypical mycobacterial infections in port sites. I mean, in public hospital, Asghar is here, port site infection, and when we do the cultures, we find this atypical mycobacteria. So in that case, we don't do the long course of typical ATT. Macrolides, they respond excellent to macrolides, 6 to 3 months of macrolides, and they just disappear.
Dr. Fariha, how would you follow up such a patient? Repeat imaging, when is the repeat imaging done? When can we expect a regression of the lesion after treatment?
So it depends what lesion we are dealing with. If it's a pseudocyst, the size definitely
Tuberculosis,
matters. Tuberculosis, yeah. So after the initiation of ATT, we go for repeat imaging after 3 months. And then we'll see is there any reduction of the lesion which was present there. So basically after 3 months of initiating the ATT, and then second imaging will be after the completion of the course. So this is the way we go for the follow-up of the patient.
If you are dealing with any infection, mind it that you should judge it clinically first, that whether the weight is increasing, the patient's symptoms are getting settled. So if that is settling, no need to go for the imaging in a particular case where we have a diagnosis that this is a tuberculosis. If patient is not responding to our treatment and the patient is not and he is compliant to the medication as well, then yes, we have to reassess at 3 months' time.
So by imaging, I do not particularly mean CT and MRI. Ultrasound is also an imaging modality which is non-invasive and very handy. So there is no harm in doing ultrasound of the patient.
Okay, ma'am. Thank you.
So I have a question from my panel. Can anybody know that is there any chance of ductal fibrosis even by giving ATT or even after the ATT? Is there any chance of pancreatic ductal fibrosis, or is there any role of steroids in that scenario?
The steroids are indicated in 2 conditions as far as guidelines are concerned, that we need to give steroids in tuberculosis meningitis and pericarditis. Rest we won't be giving steroids, though steroid have very effective, if the patient have large pleural effusion, we used to see that if we give steroid to them, the pleural effusion will go in 2 weeks or 3 weeks time. But particularly for this thing, whether it will prevent pancreatic duct fibrosis, I'm not sure, because the pancreatic duct is not involved in our case as well. So if the duct is involved, then yes, it can have some effect, but otherwise not.
Thank you, sir. Thank you very much.
Sorry, I was about to say that I think TB spine with the paralytic ileus, I think steroid also needed there. I think 3 conditions, meningitis, pericarditis and...
Even in spine, if you have neurological involvement, then yes, if the spinal cord is involved, then yes, that would be again another case to reduce the edema. Yes, otherwise, it's not required for in fact bone tuberculosis.
Yes, okay, yes. Thank you.
That concludes our third case.
Thank you.
Before we leave, just take home message. Let the radiologist decide what investigation should be done.
Okay,